the definition of palliative care, which is a form of medical care focused on improving quality of life for people with serious illness, as well as for their families. And I'll just begin by telling you a quick story about a patient we took care of who was 24 years old and had acute leukemia, new diagnosis of acute leukemia, uninsured because that's the way our country is. 24 years old, no health insurance, working as a waitress, saving money to go on a backpacking trip to Australia. Had been having headaches and nosebleeds, which she attributed to dry New York apartment air and not sleeping enough. Was found collapsed on the floor of her apartment by her roommate, unarousable. Happened to come to the Mount Sinai, my hospital's emergency department, where she had about 250,000 blasts on her CBC, platelet count not measurable, like less than 5,000, hemoglobin of 3. You have to be 24 to survive those numbers. So really, really sick with a new diagnosis of acute leukemia, no insurance. So she did get emergency Medicaid, was admitted to the hospital for induction chemotherapy. And we didn't get, and had terrible pain from blasts in the bone marrow. Just terrible, diffuse skeletal pain. That was, as she later described it, 20 on a scale of 0 to 10. We were called about 6 days into the stay when she had started her induction chemotherapy, and I happened to be the attending on the palliative care service that day, completely randomly. And the intern or the resident who called said that they needed our help with a manipulative drug-seeking patient. That was the reason for the consult. So I asked a little bit more about it and heard she was 24 years old with a new diagnosis of leukemia, and that they were giving her pain medicine, but she kept demanding more, and they wanted help. So we went up on the elevator, and you get off the elevator in the building that the Mount Sinai Hospital is in, and it's a good quarter mile from the elevator to where the patient is, maybe an eighth of a mile, and you could hear this young woman screaming from the elevator. So she was on, guess what drug? With how much? 1 to 2, yeah. Q6. PRN. Pain. Okay, this is my hospital where there had been a palliative care team for, at that time, maybe 4 or 5 years. This is what the house staff know what to do. Okay. So, what was happening is she'd get these 2 Tylenol 3, and by about 2 or 3 hours, she had no benefit in the first place, but things just got more and more excruciating. So 3 hours, she's sitting on the call bell, and the nurses are saying, Kate, you have to wait until whatever it is, 2 p.m., why are you pushing the call bell? You just got your medicine. By 4 or 5 hours, she was yelling and screaming. The door to her room was shut because she was in isolation, but I think was also shut for other reasons. And fascinatingly, the house staff, which are her age, they were peers, had sort of shut her out as not human, but as a problem. A mentally ill problem who needed to be kept in her corner and not acceded to because they didn't know. And she later said, by the way, that being treated like a manipulative drug seeker, like someone whose word couldn't be trusted, was the worst aspect of the entire experience because she was dehumanized, made not a valuable, to seem not a equal, not a human being in the eyes of the people whose job it was to save her life, that it was terrifying. So, of course, it was actually quite easy to get her pain under control, so we got her on morphine on an every 3-hourly standing basis with rescue doses that could be given every 30 minutes as needed for pain that was not relieved by standing medication. And within a couple hours, she was restored to her regular self. Sweet, funny, sarcastic, making jokes out of this terrible disease she had been struck with. I'll never forget the faces of the interns and the residents seeing that basically they just didn't know what to do. No one had taught them. So the assumption among physicians, especially when we don't know what to do, is that it must not be important to know. Because if it was important to know, we would have been taught how to do it. And I think that's a big piece of what's behind the epidemic of inadequate pain management in our country. So Kate did go on to get cured through bone marrow transplant. She was in the hospital for about 9 months, I think. It was not an easy time. It was extremely difficult also because she was from a large Catholic family, 5 kids. Her oldest sibling, her brother, was a substance abuser, recovered, but her parents didn't want her to ever have any opioids. So the degree of spiritual, existential, and emotional suffering, bad enough that this beautiful child had been stricken so young, was greatly complicated by this powerful belief that opioids were evil. So we spent a lot of time. We spent 2 to 3 hours at the bedside almost every day for the first several months of her admission. The hematologist came by in the morning, checked the counts, wrote the orders, and left. This patient sends us from her school teacher salary $1,000 a year at Christmas every year, and her parents send us more. With letters that say, you saved our daughter's life. So I want you to remember Kate's story because she's alive. She was cured. She's about 6 years later now. So she wasn't dying. If we had had to wait till people labeled her as dying or likely not to benefit from life-prolonging treatment, she probably wouldn't have made it, because she wouldn't have had any relief of symptoms that were so severe that they could have killed her. So palliative care is certainly important for the dying, especially hospice, because it's the highest form, the most intensive form of palliative care that people who are dying and their families need. But palliative care is for everybody with a serious illness, whether they're going to be cured like Kate, whether they're going to live for 10 or 20 years, with a chronic disease like Alzheimer's, or heart failure, or emphysema, or frailty with functional impairment, or children born with congenital birth or genetic defects. In fact, the majority of kids who need palliative care do not have cancer. They have chronic diseases which would have killed them quickly 20 years ago, but with which they now live for many, many years, if not decades, thanks to modern technology. So it's not about the dying, it's about the living, and trying to make the quality of life for the patient and their family as good as it possibly can be. So once we have all agreed on that definition, the question is where to go in the future. Why do you think it is that it's mostly hospitals that have palliative care teams right now in the United States?